I thought I'd start with a quote, my favorite one that I think about almost every day, kind of statement of intent, if you will, and that's that the action most worth watching is not at the center of things, but where the edges meet. So I chose to become a kidney specialist because it requires me every day to stand at multiple points of tangency where the edges meet and think about how different concepts, diseases and people interact. And I sometimes joke to my medical students that this is why nephrologists make great administrators and chief medical officers. Now, so on any day that I'm not at the George, I'm often starting my day in the maternity unit, seeing a pregnant woman with high blood pressure and protein in the urine who has preeclampsia. I might then go up to the coronary care unit and see an elderly man with heart failure and kidney disease, and then make my way over to intensive care where I might see someone with leukemia who's got a serious infection that's caused their kidneys to fail. People rarely just have kidney disease, they often have multiple conditions at the same time once the kidneys are affected. The other reason I chose to specialise in kidney disease is because I realised really early on that it's a massive problem. I spent 7 years training and working up in far north Queensland, and I thought I'd remember these rare infectious tropical diseases, but what really struck me was the burden of kidney failure, particularly amongst Indigenous Australians. Kidney disease affects about 700 million people worldwide, that's about 1 in 10 of us, and aside from dementia, it's the fastest rising cause of premature death globally. One of the proudest things I've achieved over the last 4 years has been establishing an international consortium for a class of medicine called FLOSNs. These are drugs that Brendon alluded to that benefit the kidney and the heart. These drugs are responsible last year for an annual revenue of about 15 billion in 2025 alone. And by threading the needle and understanding the intersecting interests, priorities and concerns of the pharmaceutical industry and the trialists who conducted these studies, we've been able to pool all of the major studies to really pinpoint who benefits and to what extent from these drugs. And what's the outcome of all of that? We've been able to change how these drugs are used, how they're prescribed for the benefit of hundreds of millions of people worldwide. But not always do we find that the commercial interests are aligned in health and medical research. Sometimes there are really important problems, the benefits might be large, but those interests, commercial opportunities aren't aligned. And one of my mentors at Oxford used to say, you only have 1 or 2 of these chances in your life, the big ideas that won't get done unless you do them. That's what the George is all about. And I'm at the crossroads of one of those points at the moment. Iron deficiency is very common. Low iron levels are common in people with kidney disease, they're common in people with heart failure, and they contribute to poorer quality of life, more fatigue, more breathlessness, and they increase the strain on the heart. Yet guidelines currently recommend only treating iron deficiency in people with kidney disease once it's caused anemia. But we know many people with kidney disease have iron deficiency and don't even have anemia. They're living at increased risk of heart disease and with poorer quality of life without knowing why. That's why I'm leading a study called the Iron Heart Trial. This is a study that will evaluate the effect of intravenous iron on how people with kidney disease feel, function and survive. It's aiming to enrol 1,200 people globally with kidney disease in 60 hospitals in 5 countries around the world. If iron works the way that we think it will, this low-cost intervention could be implemented rapidly at scale in almost every healthcare setting around the world for the benefit of millions of people with kidney disease, including the 2.5 million Australians who are already afflicted by the disease. Pharmaceutical company called Pharmacosmos, they're Danish, have already committed to providing the drug free of charge for the study. And whilst that's important and reduces the costs, it's also a massive vote of confidence in the study itself and the international team that we've compiled to get this done. So I became a nephrologist because I'm drawn to the edges where different diseases, different risks and different opportunities intersect. And this trial, Ironheart CKD, sits squarely at one of those intersections between the kidney and the heart, between a preventable hospitalisation and a costly one, what we currently do and what might be possible in the future. And with your support, we have the opportunity to not only ask this question, but then to deliver a reliable answer for the millions of people living worldwide with kidney disease. Thank you very much for your attention.